And welcome to the Dr. Bob Show. The leading cause of death in the United States is cardiovascular disease. So we're going to be spending this show talking about the heart doctor, cardiologist, and what tests he can order that will tell us how your heart is doing. My guest is Dr. Josh Todd. Dr. Todd is a board-certified cardiologist, and he'll be teaching us the difference between electrocardiograms, echocardiograms, Holter monitors, MRIs, perfusion tests. All of these tests help evaluate our hearts so that we can keep them healthy. He has all the answers. Hello, I'm Dr. Robert Overholt. I'll be your host for the next 30 minutes on the Dr. Bob Show. Later on, we'll be talking about not only how we measure the heart, but how we measure the lungs and some of the problems that we have with too much sun. A lot of information for you. You'll want to stay tuned. We're talking with Dr. Josh Todd, board-certified cardiologist, and we're talking about what cardiology tests does the cardiologist order and why. Josh, welcome to the Dr. Bob Show.
Thanks again, Dr. Bob. Enjoyed being here.
We've already stated that cardiovascular disease is the leading cause of death in the United States. Let's look at the heart and see what tests we run. First of all, everybody knows about an electrocardiogram. That's an EKG, same thing?
Correct, yeah.
What is an EKG?
Yeah, so an electrocardiogram, one is probably the oldest test we have. The initial EKG was performed with a guy with a hand and some feet and some salt buckets, and then somebody described electrical signals they could measure. It gives us still a lot of information. It's the cheapest, oldest test we have, but it still can give us some information on, one, rhythm disturbances with the heart. Two, it can give us some information if you're actively having symptoms. Are you having a heart attack or one that we need to rush you to the lab on? And it can give us an indication on if you've had old heart attacks. It can give us an indication on do you have any conduction system abnormalities that may put you at risk for certain devices, or are you at risk for having passing out episodes or what we call syncope.
If you've got 100 patients that you've got electrocardiogram on and they're coming to see you for their heart, yeah, how many of those will have some abnormality that's significant?
Right. I think it depends on the age. If I see, 120-year-olds, maybe one. If I see 170-year-olds, then probably 30% of them will have something on there that we use to describe. And again, it can tell us about structure, such as chamber enlargement, and that tells me have you had hypertension or high blood pressure for a long period of time.
So a chamber enlargement. What's a chamber?
So heart has 4 chambers. There's 2 upper chambers, 2 lower chambers. The left ventricle, which is the main pumping chamber, over time, if you have high blood pressure, that heart muscle can get a little thick.
And you can see that on electrocardiogram.
We can see that on electrocardiogram.
So part of it gets bigger. There's more electrical activity that has to go through that muscle.
Absolutely. It's like working at your bicep. It gets bigger too there.
So what kind of rhythm disturbances will an electrocardiogram tell you?
Pretty much all rhythm disturbances are diagnosed with an electrocardiogram. AFib's probably the most, or atrial fibrillation is the most common rhythm we see. We can diagnose various heart blocks, meaning the top and the bottom chamber don't communicate very well. And when they start miscommunicating, that's when pacemakers are indicated. And then there are some dangerous or malignant rhythms we can see called ventricular tachycardia that we can diagnose with that as well.
Do people come into your office saying, well, I've got a run, like boop, 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 boop,
absolutely,
for 5 or 6 seconds of an irregular heart rhythm, and they don't have any heart rhythm problem when they come into your office and you get the electrocardiogram. What do you do to check that out?
Yeah, as I tell my patients when I get the electrocardiogram, for that 10 seconds of your life, you looked great. So that's really all that electrocardiogram tells us. So a lot of times we'll do home monitoring, and it's similar to when you come in the hospital and you have that telemetry monitoring. This allows people to be monitored at home. We have different flavors of them. One is what's called a Holter monitor, which is a shorter duration. Usually that'll be for 24 or 48 hours.
So do you hook the patient up? How do you hook them up?
Yeah, the older Holter monitors did require a lot of wires, so they would wear patches and they had a device and they were stuck to that for that time period. Our newer monitors and most of the technology is moving towards patch-based devices that connect with a Bluetooth to a telephone that we give you.
How fast can you get that information?
Within seconds. It's there. And I can real time, even on my phone, patients can call me at night and I can tell what rhythm they're in real time, which is very interesting.
Now, you mentioned atrial fibrillation and ventricular tachycardia or fibrillation. Where is the big deal on that? Ventricular?
Yeah, well, so the most dangerous rhythm obviously is the ventricular rhythms, because that's what causes sudden cardiac death. We've gotten real interested with these devices in terms of looking at atrial fibrillation, because it can cause you to have an increased stroke risk at times. And so that's what we're using most of our monitoring for now, is after patients have had strokes, really looking for atrial fibrillation, because it impacts how I treat you with blood thinning medicine going forward.
So teach me how atrial fibrillation, one of the chambers, the atria, produces a stroke.
Right, so what happens with atrial fibrillation, the top chamber that's supposed to be squeezing, it turns into this chaotic disturbance. It's like a noisy classroom of children, right? So they're running around and the top chamber's wiggling like a bag of worms. When it does that and not contracting, blood clots can form, and those clots travel from that upper chamber through the lower chamber and up to the brain.
Okay. So when you get a clot that goes up the brain, that's your stroke that's there.
Exactly.
Somebody told me 25% of strokes could be due to atrial fibrillation.
And to be honest with you, we're diagnosing them more now that our technology has gotten better on picking up atrial fibrillation after stroke. It's probably a little higher than that now.
Wow, so it's a really significant thing.
Absolutely.
So if somebody comes in saying their heart has runs of abnormal beats, or they can feel their heart pound like that, it's very important that you find out if it's atrial fib or something else. What would be some of the other things other than atrial fibrillation?
Right, and atrial fibrillation, again, stroke risk. The other arrhythmias, and there's a list of 10 different ones, but you can have what's called an atrial tachycardia. The difference between that and atrial fibrillation is it's one or two cells that are irritable rather than the whole chamber. You can have certain types of supraventricular tachycardias that involve the middle part of the heart that we can ablate, and we can find those as well. That's usually a young person's heart rhythm that we find.
How do you ablate? What does that mean? How do you ablate a rhythm problem?
Right, so we got, with certain rhythms in the heart, we know where they live in the heart. And so the electrophysiologist, the electrician, can go up with a special catheter that's either hot or cold, and they can go find where that group of cells live and get rid of it. Certain ablations that we do for SVT or supraventricular tachycardia, it's because you have an extra electrical tissue in the middle part of your heart that we can get rid of and permanently stop that rhythm disturbance.
Is our ability to take care of these rhythm problems improving every 3 to 5 years? It just seems like the advances in medicine are so fast.
Absolutely.
Especially with cardiovascular rhythm disturbances.
Yeah. The amount of patients with these rhythm disturbances is growing every year. We're getting older as a population, probably more unhealthy as a population, and if you get old enough, you'll have AFib or some of these rhythm disturbances.
Yeah, that's an interesting statement. If you get old enough, you're going to probably have atrial fib. That means everybody that lives to between 80 and 90, somewhere there, will have developed atrial fib. Yeah. So it's really important that we find that early. How often should a person get an electrocardiogram?
That's a little bit of a gray area. Depending on what I'm treating them for, a lot of patients can detect if they're in the rhythm just by symptoms.
Yes.
So if you're on stable medications, on antiarrhythmic medicines, I'll get it every 6 months or so on antiarrhythmics. If you have had AFib once in your life and you knew when you had it, we don't necessarily have to have an electrocardiogram. Medicare physical, I think, requires one a year once you hit 65 and older. But it depends on what the patient's diagnosis is and what we're looking for.
And I guess the other parts of the patient's physical and history, the high blood pressure, cholesterol, and their general health in general. Mm-hmm. The electrocardiogram then can tell us if a chamber is enlarged, mm-hmm. If the conduction inside the chambers is correct. How can the electrocardiogram tell you how good the heart is working? Or do we have to have something else?
It can tell us if you've had a big heart attack before, because we can see some areas that say the bottom wall of your heart has lost its electrical signal, and so I can make some assumptions, but I can't tell what the squeezing function is by the electrocardiogram.
So is there something called an echocardiogram?
Correct, yeah, echo meaning sound, and so we use ultrasounds to beam through the chest wall to pick up the heart muscle.
And the echocardiogram, can it tell how the heart is beating and squeezing and how much blood's coming out?
Yeah, we get a lot of information from our echocardiograms now. We can tell about heart function in both the left ventricle, which is the main pumping chamber, the right ventricle, and it can tell us whether or not you have high blood pressures in the lungs.
Which is more important, the electrocardiogram or the echocardiogram?
They give us complementary information.
And that's what we're going to be talking about when we come back. How much information do you get with an echocardiogram, and how does it differ from the EKG, electrocardiogram? We're talking with Dr. Josh Todd, board-certified cardiologist. We're talking about tests that the cardiologist orders. We've been talking about the electrocardiogram and how it can tell the rhythms, how fast the heart's beating, how big some of the chambers are of the heart, if the chambers are not reacting properly, if somebody's had an old heart attack even. Lots of information on the electrocardiogram. Now we're switching to an echocardiogram, and that's where you've got sonar waves that are telling us what the shape of the heart is and how it's beating?
Absolutely, yeah. We again, it's an ultrasound tech that will get those images for us, and there are two main places we get the ultrasound from. We'll get it right on the side of your sternum, and we'll get it right at the apex of your heart. And so we'll generally get the heart in about 8 different views, depending on how the heart's oriented.
What are you looking for mainly in an echocardiogram?
Yeah, so the big picture is one heart function. So we'll give something called an ejection fraction.
Ejection fraction.
Right. So what that means is how much blood that's put in your heart gets squirted out, okay? Normal is more than 50% or greater, so half the blood that comes in your heart should be ejected out. We have various ways of measuring that. Most commonly it's the eyeball factor, meaning you put 10 cardiologists in a room and we can all look at an echo and get within 5% of each other. That's what we spend all our training for when we read echoes. There are some different ways we can measure the ejection fraction, which seems to be a little more objective.
Now the left ventricular ejection fraction.
Correct.
That's the big pump.
That's the big pump.
So is that the most important ejection fraction that comes from the left ventricle?
It is, yeah. We can't really evaluate the right ventricular ejection fraction. It's either abnormal or not. But yeah, the left ventricular ejection fraction tells us lots of things. It tells us, one, if you're a candidate for an ICD or defibrillator, okay? It kind of gives us an idea of what the cardiac output or is, are your low blood pressures related to a reduced ejection fraction as well.
So if somebody has a value, 50% being normal, 50% of the blood that comes into the left ventricle is squirted out. If it gets down to 40 or 35 or 45, when do you begin to worry?
Yeah, but probably 40% or less is where we've called this heart failure with with reduced ejection fraction is that number. At 35% or less is when we start worrying about sudden cardiac death, and we think about defibrillators at that point. But the medications really change at 40% on how we manage that, and also do we need to start thinking about doing heart catheterizations and look for blocked arteries at that point if we get that number.
So if somebody's got a 40%, that's abnormal, ejection fraction, you begin to look at why the heart's not beating strong.
Absolutely, yeah.
And therefore you have to look at the coronary arteries.
In the U.S., in somebody over the age of 45, and especially in East Tennessee, that's my number one stop. If that's not the answer, then we think of other things that can infiltrate the heart, genetic reasons or viruses that can affect the heart at that point.
So if it's the coronary arteries that are not supplying the muscle with the ability to eject the blood that's there, the main causes of coronary artery disease would be smoking,
yes,
overweight, high blood pressure, all things that we can work on, that we can change.
Well, a lot of those things, yeah, probably 60% of it's genetic, whatever mom and dad give you, and you can't usually pick your parents.
And it's so much important now, the family history of what mom and dad gave you.
Yeah. And so it's real important if you do have a family history to not, to take care of your body then. It's, the smoking and not getting diabetes and exercising and eating correctly. So all of those are big factors.
You spend a lot of your time as a cardiologist teaching people those quality of life things that we can do to stay healthy?
Yeah, absolutely. That's probably the most long-standing things they can do to help themselves. A lot of my patients want to say, hey, doc, give me a pill and tell me, let's get this fixed quickly. But those patients that embrace all of the above, medications and lifestyle modification, meaning diet, exercise, those are the patients that do the best.
Yeah, and that certainly sounds reasonable if it's done that way. So back to the echocardiogram and back to the information that it gives us. What medication guideline do you use? If the ejection fraction is not good enough, how do you make it gooder?
Yeah. So again, it's to look for easily fixable things like blocked arteries, and if it's not that, if it's let's just say a virus that has affected the heart, we use things called beta blockers. We use ACE inhibitors or angiotensin receptor blockers. There are newer agents out there we can use that have just been approved for heart failure. That one class used to be a diabetes drug and makes you pee with sugar, and so we found out that helps with heart failure. There's another drug called Entresto that we now can use. There's a lot of commercials on TV about that, and again, that makes you get rid of fluid with something called BNP.
BNP?
BNP.
And what does that tell you, that BNP? Is that a blood test?
Yeah, it's a blood test. When you're in heart failure, the top chamber of the heart can stretch. That stretching releases this hormone, and that tells us, yeah, you're likely to be in heart failure if it's really elevated. But your body releases that on purpose. It tells your kidneys to dump water. And so what we can do with one of the medicines is keep more of that circulating around. That helps get rid of fluid, and that's when Entresto, one of the drugs in there, helps you get rid of fluid that way and with BNP.
It used to be that, as I would read the heart literature, that congestive heart failure was a kiss of death, that the 5-year survival was very, very poor.
Right.
Now it seems to be getting better and better because of the medication.
Medications, procedures, our new devices, LVADs and things like that, which are left ventricular assist devices, and they're special heart pumps that can be implanted. It used to be somebody with a 10% ejection fraction had a worse prognosis than somebody, say, with cancer. And nowadays it's not always that way.
Which is amazing, encouraging, enlightening, exciting, all of those things that the cardiologist is able to do to help us. Now, let's evaluate the coronary arteries. How do we do that? What type of test do we have?
Yeah, usually we'll use, we can look at coronary arteries two ways. One is with anatomy, or the other is with how they're functioning. So stress testing, we're looking at, are the arteries blocked more than, say, 70% to not provide enough blood flow to the heart muscle. And so stress testing looks at the physiology of stressing the heart or exercising the heart or giving them a medication to say, are there areas of the heart that aren't getting enough blood flow when we put it under stress?
And when you put it under stress, that's a stress test.
Correct, yes.
So the heart muscle during stress needs more blood flow. If it doesn't get it, you read it how?
Yeah, so there's different ways. There's just a routine treadmill, which we will put you on a treadmill and we look at it with the electrocardiogram. That type of stress test, although cheap and historically the first thing we would start with, has got about a 60% accuracy rate on picking it up and being accurate with the blockage. So if we have a lower risk person, young person, and they do great on a treadmill 10 minutes, they're pretty low risk for events. If we're concerned about it, we have some imaging we can use, one with a nuclear dye that goes to heart muscle, or two, we can go back to that ultrasound and use an echocardiogram as the separate imaging modality to figure that out.
Can you do the echocardiogram, the sonar waves? Can you do that while you're doing the stress test?
Yeah.
And does the electrocardiogram change if the coronary arteries are not supplying enough blood?
Yeah,
adequate
absolutely.
supply?
That's what's called a stress echo. We'll get some baseline images when you're sitting, before we put you on the treadmill. We do the treadmill and we look at you with the EKG, and then when we get you to target, we quickly get you back on your side and look at your heart muscle again. And if I see heart muscle that's not moving after the treadmill, it means there's not enough blood flow to that area.
So then you've got to make some decisions on how to take care of the coronary arteries. Is surgery part of that? Stents probably that?
Yeah.
Angiograms, correcting the coronary arteries?
Correct, yes.
And you all are amazing at how you do that. I mean, it just amazes me of what you can do to open up the coronary vessels that need to be opened up, that you find out with all these tests. Many more tests that you order?
Yeah, so there's a CT angiogram, which we're starting to use more.
And that's what we're going to be talking about, CT angiogram. So we'll get a CT to measure the blood flow through the coronary arteries and see what that tells us. And also, I'm going to talk about a calcium score. A lot of information. We're talking with Dr. Josh Todd, board-certified cardiologist, and we're talking about how tests that he orders allow us to understand how your heart is functioning. Now we're getting into the coronary arteries and to see how they're functioning, to see how we can help them. So tell me about a CT angiogram. What is that?
So CT is just a CAT scan. So it's a tube in which we're giving X-rays through your body.
Can you pick one little vessel and walk through that vessel?
Yeah, the resolution has got pretty good. Initially, 10, 15 years ago, how fast that X-ray tube could spin impacted it. Now we've got some scanners that can spin 256 times a minute. And so we get really good pictures, imaging, and resolution. It's different between a black and white TV and HD. You know?
Does that get to be more and more fascinating to the cardiologist to be able to see those advances? Well, 10 years ago we could only see this, and now it's just right there in front of us like it is.
Absolutely. So the imaging we get is incredible now in terms of looking inside the heart.
So we know what the ejection fraction is. We know how the coronary arteries are opened and how they're functioning. What's our next decisions?
Yeah, so again, that CT angiogram, what it does is gives me some anatomical pictures of the heart. You've got three main heart arteries, two on the left and one on the right, and we will, like you said, we'll look at each one individually. And we're looking for blockages and calcium in those arteries to see whether or not there's flow limitations.
How do you get rid of the blockages?
So that's where heart catheterization comes in, where we put in the tiny tubes in. We'll go through your wrist usually. Put in tiny tubes, take pictures, and if there's a blockage or two that's focal, we can fix those with stents. We still do bypass surgery in certain patients or open heart surgery, but that's when we have diffuse blockages or it's at the trunk of the tree now, or left main.
So what I'm hearing is the cardiologist has a large armamentarium of tests that he can help the patient visualize the function of their heart and give them an idea of what they need to do with medications and lifestyle changes such as stopping smoking, losing weight, eating better. There's just lots of things go into the picture of being healthy.
Right.
Josh Todd, you're a wonderful teacher. Thank you so much for coming to the Dr. Bob Show. Hope you'll come back again quickly.
Yes, sir. Thanks again for having me.
And remember those three things that we like: to do that we mention on every Dr. Bob show. Number one is exercise. You've got to be able to exercise on a regular basis. It will improve your heart tremendously. It will actually form collateral circulation, new blood vessels there to help nourish the heart. Eat properly, eat fresh fruits and vegetables. Stay away from fried, fatty foods. We know what we should eat. Do a better job of eating less and exercising more. 7.5 hours sleep. If you can get 7.5 hours of good sleep, it will make your life better. It will make your immune system better. It will make you healthier. And most of all, what is it we like in the Dr. Bob show? It's that laughter in your life. So as we're using exercise and eating and sleeping and laughing, always remember that that's going to improve your health. I wanted to mention two other things. Number one, sun exposure. There's ultraviolet radiation that comes from the sun. There's UVA and UVB. There's a UVC, but we don't need to know that much about. UVA has a longer wavelength. It will destroy some of the tissues in the skin that keep us from having wrinkles. So as we get more sun exposure, UVA will get more problems. It can also increase the incidence of skin cancers. UVB, we get sunburns. It damages the skin. So when we use sunscreens, we need to use UVA and UVB. Get in the habit of using sunscreens. When you wake up in the morning, you put on your makeup or you do your shaving, get some UVA, UVB. A 30 SPF is what you want, and then you'll be healthier. So use those four things that we like: exercising, eating properly, sleeping properly, and most of all, having that laughter in your life. Are you giggling enough? Do you pick that person out? You tell funny stories that I remember when, it'll make you laugh. That will relax everything and you'll stay healthier.